Today we're going to look at Chapter 18, Diseases of the Nervous System and Sense Organs, and this corresponds to Chapters 6 through 8 in the code book. Let's talk about the nervous system now. The nervous system is broken down into the central nervous system and the peripheral nervous system. So really any diagnosis that affects the brain and the spinal cord is going to come under the central nervous system, and everything else throughout the body is going to come under the peripheral nervous system. Notice that the autonomic nervous system is what regulates the activity of the cardiac muscle, your heart muscle, the smooth muscle, which is along your GI tract, and your glands. Okay, let's look at exercise 18.1 number 2, and this is a poliovirus encephalitis. And I made you a little note here. You code the poliovirus as poliomyelitis. The more you're in the code book, and this is why I encourage you to just be in it as much as you can, because you're going to see times when certain words are always used in place of another word, and the same words are not always used in the medical record as they are in the code book. So you learn what to look for. This is one example where poliovirus would be coded as poliomyelitis. Another good example that I remember when I was learning to code, an amputation is coded as absence of limb. So you just learn where your pathway begins. In this case, you can see that poliovirus encephalitis requires 2 codes, and that is one of the very first coding guidelines. A is a convention. Remember, we just looked at Section 1A is conventions, and this is the etiology manifestation convention where you have a code first and use additional code. So when we look up polio, we get this code. But if we had started with encephalitis and had followed down our indentations in our alphabetical index, it would have taken us to the same code, and we would see this is the polio code followed by the manifestation code. The GO5.3 is the encephalitis. So that's a good example of manifestation convention. I have this exercise for a couple of reasons. One is to notice that the terms intractable and poorly controlled mean the same thing. Intractable is a term that you often read in the medical record. It describes many things. You could have intractable headaches, intractable migraines. You could have other diseases that are intractable symptoms. So just remember these terms, intractable and poorly controlled, mean the same thing. And here's the pathway. Pretty simple. Epilepsy, generalized, idiopathic, intractable. The point I want to make with epilepsy is taken from the code book on page 205. Similar to AIDS, you cannot code epilepsy unless you have a physician saying it very clearly that this person has epilepsy. I don't know if you've ever known anyone with epilepsy, but it affects their life in many ways, one of which is they can't get a driver's license. So in our society, if you live out in the country, for example, that's a very big obstacle for someone to overcome. So you don't want to ever give someone that diagnosis unless it is very clearly identified. And if it's not clearly identified, a query to the physician is certainly in order. Okay, I wanted to talk about this disease. Alzheimer's disease with delirium is exercise 18.2 number 7. The coding handbook, I have the answers in the coding handbook, and she gives the answer as G30.9 because in this particular diagnosis that we've been given, Alzheimer's disease with delirium, there's no mention of any dementia. But I have never seen Alzheimer's disease documented without dementia in all the years I've been reading medical records. So if I were in the hospital and I saw this, I would query a physician if I saw only Alzheimer's disease with no mention of dementia. So I've given you the pathway to get the code that she gave as the answer for G30.9, but even in the alphabetical index you see a manifestation code of F02.80. there's an instructional note just under the G30 category to use the additional code to identify any delirium, and that's F05. But there's also the use additional code to identify these dementias with behavioral and without behavioral disturbance. When you go to the FO2 category, there's an instructional note to code first any underlying physiological condition, and the first one is Alzheimer's. So let's look in the tabular so we can talk about that for a minute. So you see here the Alzheimer's disease. This is what I'm talking about. Use additional code to identify delirium, which in this case it did give us the F05, and to identify these dementias with or without behavioral disturbance. It also has options for a fourth character for early onset, late onset, or other. Our documentation didn't give us the onset, so we would always use this unspecified code. But what is confusing to me is when you look at the alphabetical index, it does not give you really the option to code just the G30 code. So let's look at the alphabetical index. Okay, in the alphabetical index, there's Alzheimer's G30.9 with a manifestation code here. So there is no option when you look in the alphabetical index for not coding that manifestation code. So to me that's a little confusing. So the only point I want to make to you is when you get in the real world and you're reading a medical record, if you see a diagnosis of Alzheimer's disease that does not mention any behavioral disturbance or dementia, I would question that. There are certain coding guidelines that are specific to only certain codes, and coding guideline 1C6A is for codes from category G81 and subcategories G83.1.2 and .3. And this guideline tells us when information, in other words the medical record documentation, is not available regarding whether the affected side is dominant or non-dominant, and the classification, which is the code, does not provide a default, this is how you select your code. If the patient is ambidextrous, the default is dominant. If the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. And I'm sure this is because the majority of people are right-hand dominant. I have several children who are left-hand dominant, children and grandchildren who are left-hand dominant. So that's not true in every family. But for general purposes, this is the guideline that we're going to follow. Also, if a person has hemiplegia and a stroke, a CVA, hemiplegia is not inherent. In other words, not every person who has a stroke has hemiplegia. Therefore, a code from category G81 is assigned as an additional code when it occurs, even if it resolves without treatment by the time the patient is discharged. Not uncommon for a patient to come to the ER, be complaining of whatever stroke symptoms they have. They have some weakness on one side, and by the time they come into the hospital and they're treated and they leave, that weakness has subsided or it's gotten a lot better. You're still going to code it because it did happen and it required additional resources to take care of the patient. Okay, let's look at this exercise, 18.3, number 2. A couple of things I want you to notice in this exercise. A cerebrovascular accident and a cerebral infarct and a stroke are terms that are used interchangeably in documentation, and that left-sided weakness is referring to hemiplegia. You would code the stroke as an accident, cerebrovascular, I63.9, and then your hemiplegia, G81.9 dash, that dash meaning we need additional characters. So that takes us to the same guideline that we just looked at a little bit earlier. When information is not available regarding the affected side, and when the classification doesn't provide a default, how do you code it? And in this case, we're looking at left-sided weakness. So we go to this part of the guideline. If the left side is affected, the default is non-dominant. So the final code, G81.94, is hemiplegia unspecified, affecting the left non-dominant side. That's how we get to this code. Okay. Now let's look at exercise 18.3, number 3. Severe hypertension and pounding headache due to autonomic dysreflexia due to fecal impaction. I have a link here to more information, and this is talking about autonomic dysreflexia. If you're working, for example, at Craig Hospital, or really anywhere, any trauma center that's treating a spinal cord injury and rehabbing a spinal cord injury, autonomic dysreflexia is so important. It can be deadly if it's not addressed quickly. Especially, I remember I used to work in a rehab hospital, and part of providing rehab services to a spinal cord injured patient is to teach them how to take care of themselves now that they have this injury. And one of those things was teaching them how do you recognize the signs and symptoms that you're getting into trouble with autonomic dysreflexia. And when you go to this code, G90.4, there is an instructional note to use an additional code to identify the cause, and that's where we get to the fecal impaction. You can also look it up here, and of course the hypertension is coded I10. Here's an exercise not in the coding handbook. As you know, I like to give you these because I think we need to look at exercises that use more of the coding guidelines than she does in the coding handbook. This one is an outpatient. Patient presents to the clinic today for treatment of severe chronic back pain due to trauma. He will receive an injection of steroid into the spinal canal to help with the pain. I've made a little bit of an exception to the way you're accustomed to seeing these slides, in that I had to move the pathways over here to make room for these 3 coding guidelines that apply to this case. The pathway is pain chronic due to trauma, pretty straightforward, but note that there is an excludes to note under the G89 code where you can use localized pain by site, lumbar region, and that's what we've done. As a reminder, excludes to notes mean you can code this code and this code. If you had an excludes one note, you could only code one of those things. And here's the guidelines. They are in a similar family. That one is 1C6B1A, 1C6B1B little I, and 1C6B1B 2 little i's. And this is when you are using the code G89 as a principal or the first listed. In this case, since we're in a clinic, it would be called first listed. It would not be called principal. You're using G89 as your first listed, and that's acceptable because pain management is the reason for this person's encounter, and the underlying cause should be reported as an additional diagnosis. And this one also applies. Codes from category G89 may be used in conjunction with codes that identify the site of the pain because it provides additional information. This M54.5 does not tell the reader if it's acute or chronic. So the G89.21 code, chronic, gives the coder more information. And last of all, the sequencing. If the pain management is why someone's there, G89 is first, followed by the site. But if the patient is in the hospital or the clinic for any other reason, that site-specific pain is coded first, followed by the G89 category code. So hopefully you can see where I used all 3 of those coding guidelines to be sure that I was coding this correctly. Now let's move on to Chapter 7, which is the coding of eye disorders. In the coding handbook on page 218, table 18.1, she has created a table that includes those coding guidelines from Chapter 7, but also she added more information regarding if the classification includes laterality or not. For example, some codes you have a 5th, 6th, or 7th character that identifies if it's right, left, or bilateral. Other codes do not. So that's why you need sometimes a table like she's provided to you to be sure you're coding those accurately. Two guidelines I want to pick out and talk about from Chapter 7 are if the patient is admitted with glaucoma and that stage evolves during the admission, becoming worse or becoming better, you're going to assign the code for the highest stage that's documented. Patient comes in with stage 1, it evolves to stage 3, it resolves by the time they leave back to stage 1, you're going to code stage 3. Also, the indeterminate stage glaucoma. The 7th character 4 for the indeterminate stage is based upon the clinical documentation the physician has provided. That 4 is used when the doctor cannot make a determination. That is different from when there is no documentation regarding the stage. So just be very careful that you don't confuse that 7th character 4 with the 7th character 0. Okay, let's look at one of these. Glaucoma secondary to posterior dislocation of the lens, right eye. If we looked up glaucoma in dislocation of the lens, we get glaucoma secondary. That's where it tells us to go to. And when we do, we get to H40.5. When we look up H40.5 in the tabular, there's an instructional note to code also the underlying eye disorder. It's the right eye, so the 5th character is 1. Since there is no 6th character, the placeholder X must be used in the 6th position. The stage is not indicated in this documentation, so the 7th character is 0. And that gives us a final character of H40.51X0. Then you look up the underlying eye disorder we talked about here. Dislocation, lens posterior, H27.13-. And since it is the right eye, the 6th character is 1 for this code, so the final code is H27.131. Notice how, as with all of our exercises, we are following our instructional notes very carefully to be sure we're sequencing them correctly and to be sure that we are covering what the code book is advising us.